Thank you very much. It's great to be here, and I'm going to be talking about normal tension glaucoma, which actually is it's not so well diagnosed, and it is also an entity which is falls within the open-angle glaucoma paradigm, and is also mixed up with primary open-angle glaucoma, and well, why is it so important to know this entity? But that's mainly because 30% of our patients that are diagnosed with glaucoma actually likely probably have normal tension glaucoma, and it's important to distinguish low tension glaucoma or normal tension glaucoma from open angle glaucoma, as in primary open angle glaucoma, because these patients have a higher genetic hypersensitivity to IOP. So any patients that you have that have glaucoma that have been diagnosed with a pressure of less than 21, you should really think about whether they have normal tension glaucoma. Also because of the fact that there is multifactorial risk factors that are associated with this condition, and mainly vascular risk factors, but there are many. So not just an ocular history, but a systemic history, a thorough systemic history of the patient, considering vasospasms, Raynaud's phenomenon, migraines, coagulopathies, autoimmune disorders, thyroid disease, sleep apnea, Alzheimer's. All of these conditions have been these patients actually have a higher risk of normal tension glaucoma. And there are many others which allude to vascular endothelial dysfunction, higher blood viscosity, reduced ICP, systemic nocturnal hypertension. So really the way that you would investigate these patients should be multidisciplinary. You need to involve other clinicians if you are suspecting that these patients have normal tension glaucoma, because that is what will help you to reduce the rate of progression, not just the IOP. But of course, a full glaucoma assessment is needed, and as Professor Vernon has alluded, the patient needs a good disc assessment, the visual fields, the intraocular pressure, the gonioscopy to make sure that you're not dealing with any sort of secondary glaucoma, and also corneal pachymetry in order to try and determine their true intraocular pressure. And of course, the patient needs to undergo cardiovascular assessment and any other systems that need to be investigated as well. Now, the ocular signs, as we have already alluded, Professor Vernon has partly alluded in his talks, the signs are slightly different from what we would see in primary open-angle glaucoma, in that these patients have, it's more common for their disc to show peripupillary atrophy, inferior thinning, and as you can see here, there is an inferior thinning here and a disc hemorrhage. Now, disc hemorrhage is also more common, and the visual field is a bit deeper, and the visual field defect is also more closer to fixation. So that is why it is so important to diagnose these patients and manage them appropriately. Here's another patient where there is a superior thinning and there is a corresponding visual field defect, and you can see that there's superior thinning on the OCT also. So all of the findings really need to correlate with each other. And as we have mentioned already, there are structural differences with the optic disc in normal tension glaucoma. The cup is larger, it has peripupillar atrophy, the cups are deeper, the neuroretinal rim is more saucerized and is thinner in the temporal inferior regions. The macroganglion complex is thinner in the inferior hemifield in normal tension glaucoma. The lamina cribrosa is thinner in normal tension glaucoma, and disc hemorrhages are more common. Now, the reason I say it's more common, it is not pathognomonic of normal tension glaucoma, but they are more common in normal tension glaucoma patients. And of course, like I've already said, the visual field is closer to fixation. And the investigations, the other investigations that you may do really should be done as a multidisciplinary approach. You need to get an immunologist involved, or you need to get a neuroradiologist involved, or even a cardiovascular physician. Now, all of these things are important because mostly you will rule out a lot of these things, but it is important to test for these things because each and every entity that is systemic needs to be managed appropriately, and if that is, then hopefully you will help to halt the disease. Now, when we see a patient with normal tension glaucoma, it is a knee-jerk reaction for us to investigate them for MRI. I think it is important to say that it should be considered, but it shouldn't be done in every single patient. You really need to look for whether there is markedly asymmetric disease. So if, one cup is like 0.9 and the other is completely normal, well, then maybe something else is going on. Increased optic pallor relative to the cupping. Unusual visual field defects, especially if they're respecting the vertical midline. So then you are actually thinking of any neurological condition or a space-occupying lesion that may be causing that. Rapid progression of visual field despite the fact that you've got the intraocular pressure under control. Rapid progression of optic neuropathies, dyschromatopsia, and afferent pupillary defects that only have a mild amount of cupping. So all of these things, really, you should think about a neuroradiology. You may be missing something. Now, in terms of the management, there's not a lot of studies out there which says which medication is the best for these types of patients, but we all have the IOP-lowering agents, of course, and there's a meta-analysis that was done of 15 randomized controlled trials which showed prostaglandins as the mainstay and a beta blocker was effective at lowering the intraocular pressure. But nevertheless, there are medications out there that provide neuroprotection, and the low-tension glaucoma study, which I will allude upon a little bit later in my talk, showed that brimonidine had effective neuroprotection properties, provided that the patient actually tolerated the side effects. But there are other medications that have been postulated for treatment of normal tension glaucoma, and it very much depends on the patient. If the patient is tolerating the medication, they're getting the response that you require, then you can use that medication. Otherwise, you need to change. So calcium channel blockers have been shown to reduce progression. Budoxolol has improvement in choroidal blood flow. Dorzolamide shows increased retinal blood flow velocity. And of course, brimonidine has neuroprotective properties, as we know. Now, if that is not working, then you need to consider laser treatment. I don't think that laser treatment should be done as a standalone, and then if the patient, usually the patient will require more than just laser treatment. I think that medication and laser treatment go in hand, and really SLT would supplement the treatment, because you're aiming for a very low IOP. In these patients, you really need to go for an IOP of maybe 5 or 6, because, and still some patients will progress, as there's the collaborative normal tension glaucoma study showed also. And if you're considering even more aggressive management, then you need to think about trabeculectomy with mitomycin, or tube surgery if the patient has already had trabeculectomy. But of course, in these cases, you are more susceptible to getting hypotony because you're aiming for a very low pressure. But the disease entity requires you to have a low pressure, so it is what it is. Now the studies, there's 2 clinical studies that were done for normal tension glaucoma. There aren't that many studies out there. We really do not understand the pathogenesis of this condition. We know that there are risk factors involved, but really we do not understand the physiology and why patients still continue to progress despite all that we do. Now, the normal tension glaucoma study was done to determine the IOP, whether the IOP is a pathogenesis for NTG, and that lowering it reduce the progression of the visual field or the change in the optic nerve. So 230 patients were enrolled, the no treatment group, and the treatment group, which has which were put in the arm where you reduce the IOP by 30%, which was an arbitrary figure that was selected, and also in trabeculectomy patients that required a 20% reduction that was accepted without undergoing a second surgery. So what they found really, the endpoint was that the disc change and the visual field loss was significantly higher in the patients that were not treated as opposed to the treated group. And the time for progression was longer in the treated group as opposed to the group that was not treated. And when adjusted for cataract, the progression of the visual field was greater in the control group than the treated group. So really, there is no question that as ophthalmologists, the only thing that we can do is to reduce the IOP, but we have to be aggressive about it. The low pressure glaucoma study was done to compare whether brimonidine or timolol was better at treating these patients, because of course we know that beta blockers lower the blood pressure, especially in the night. If they're getting more than 10% of systolic or diastolic reduction in their normal blood pressure from their sleep, then these patients are more susceptible to damage. So this study was done, and it came out that essentially brimonidine was, provided these patients don't develop ocular allergy, their field was said to progress much less than, say, timolol. But again, these are studies where they're guidelines. I mean, we don't have to follow the guidelines as a strict measure. We need to really look at the patient. We need to see how they are responding. And really, there was a study that was done on clinician behavior in Canada on how they approach normal tension glaucoma. So 419 ophthalmologists were surveyed. There were 264 respondents that were glaucoma specialists. And surprisingly, there were only about 64% of ophthalmologists in that glaucoma subspecialty group that actually knew about the study, and these two studies. And of the respondents, 70% indicated that they would initiate treatment for mild to moderate normal tension glaucoma without waiting for any documented disease progression. So that means that basically you need to start treating these patients early. And despite all that, what you will do, some of these patients will still continue to progress. And, you know, of these respondents, the subspecialists felt that the low tension glaucoma study results had no impact on their usual clinical practice. And again, as I've alluded before, it very much depends on the patient. If they're getting a good response, they're very compliant with the prostaglandin, then so be it, use a prostaglandin. Their first choice was, in normal tension glaucoma, was prostaglandin analogs. And some of them were using brimonidine, provided the patient didn't have any side effects. But essentially, again, you know, in this condition, really taking a good history, a systemic history, and really going into the risk factors is very important. You need to aim for a 30% lowering of IOP from baseline, but you should really be able to get them as low as you possibly can, especially if they have risk factors, and considering their age and their visual field defect. Of course, if their visual field defect is very close to fixation, you need to be more aggressive. You need to consider their age, their lifestyle, whether they're compliant with medication. And of course, if they need to be managed surgically, you need to be aggressive. You need to aim for a very low IOP. Always consider using mitomycin or 5-FU augmentation to get their pressure as low as you possibly can. Thank you.